Hello and welcome to the Minds on the Frontline podcast. I'm Jeff Lassers, one of your hosts. I am a professional firefighter, paramedic, educator, and content creator. My co-host today is Mike Mattern, firefighter, paramedic, and a peer support team expert. In this episode, we welcome Dr. Jason Wilkinson, a clinical psychologist and assistant professor with Wayne State University's Department of Psychiatry and Behavioral Neurosciences. Dr. Wilkinson provides care through Wayne Health and works extensively with Michigan's first responders and their families through the Frontline Strong Together 5 program. Many first responders understand that trauma, disrupted sleep, chronic stress, and years of staying alert can affect how they think, feel, and function. What may be less clear is what actually happens when someone seeks clinical help and what treatment options may be available beyond traditional talk therapy or medications. During this episode, Dr. Wilkinson walks us through the initial clinical evaluation, how it helps guide treatment, and why trust between the clinician and patient matters. We break down quantitative electroencephalography, or QEEG, an assessment that measures and maps brainwave activity to provide additional information about how the brain is functioning. We explore neurofeedback, a form of brain training that uses real-time feedback from brainwave activity to help a person practice regulating patterns associated with attention, emotional regulation, sleep, and other areas of functioning. We also discuss eye movement desensitization and reprocessing, or EMDR, a trauma-focused therapy that helps people process memories that continue to trigger strong emotional and/or physical reactions. And finally, we talk about why the same event can affect people differently, how support and workplace culture can influence recovery, and where medication may fit as one tool within a larger treatment plan. The bigger message is that trauma responses do not mean someone is broken. This conversation is meant to make clinical care and these treatment options easier to understand, while offering hope that with the right support, those patterns can be treated, processed, and retrained. Minds on the Frontline is presented by the Frontline Strong Together 5 program. FST5 offers 24/7 mental and crisis support for Michigan's first responders and their families. If you or someone you know needs help now, call 1-833-34-STRONG or visit fst5.org to learn more. Wayne State University administers FST5 with grant funding from the Michigan Department of Health and Human Services. Together, we are dedicated to strengthening the health, resilience, and well-being of Michigan's frontline community. Please follow us on social media and enjoy the show. Dr. Wilkinson, how are you today, sir?
Very well. How are you?
Perfect. Thanks for joining us today.
Thank you. Appreciate being here.
Who are you? What do you do here? And how long have you been doing it?
Dr. Jason Wilkinson, work here at Wayne State University, Department of Psychiatry and Behavioral Neurosciences, work through Wayne Health. I'm a clinical mental health professional. So psychologist, counselor, consultant, assistant professor.
Fantastic. And it seems over the last couple of years, you've not only done those things with the general community, but really getting into more first responder community via FST5. You're one of the great clinicians available through Wayne Health, available to our first responders and their family members. And the number of first responders you've seen over the last probably 5 years has gradually increased, I would imagine.
Yeah, it's about 80% of my caseload.
Wow.
Actually. So been here about 10 years, and for the last 5, it's been 80% first responders.
And how did you go from that general, whoever you were seeing before, to then transitioning to more 80% of our people?
Overnight.
Really? Tell us that story.
Yeah, the program started, it was like, who do you have to get rid of? We have to discharge some people so we can get some first responders on your schedule. So it was a easy transition, to be honestly, for clinical because of the trauma specialty that.
So it's literally a position opened up.
Transitioned, for sure, yeah.
Or, in your group at Wayne Health, there was like, hey, we need a need. We see you being good for this. Jump in, both feet. And had you any contact with first responders before that?
Not much, very limited, actually. More veterans, actually, than first responders.
Okay, so at least you had like a look into that type of community, the locker room community, I like to call it.
Yep.
And that's not a sexist thing. We have plenty of that type of brain of like the team mentality.
Yep.
And a lot of first responders come from that veteran community.
Yep. Oh, yeah. He's actually come out and done third rides and see what's going on, and I give you a lot of credit for that as being one of the clinicians who's willing to come out and do that. So
thanks. Yeah, did it twice. Had a 12-hour, and then did a 24-hour just a couple months ago.
Yeah. Did it.
That's awesome.
Yeah.
Would you mind reflecting on that a little bit and gaining your cultural competency? Because every first responder I know that meets you goes, "That guy's great," right? So I think you have
That's
a
very nice,
personality.
by the way.
They really do.
They do.
All
That's
the people
nice.
that meet you that go, "Oh, I know him," they love you. And I think you have a personality that we are attracted to. So you're just an easygoing human being that anybody can kind of work with, right?
Try to be, yeah.
Which allows people to put their guard down in general. But this community seems to really like you. But you've also, I think, gotten more comfortable through your experiences. Can you kind of highlight you going from no first responders, some veterans, to, hey, you're going to play right wing over here and do this with these people over here?
Yeah, I enjoyed the third ride. I didn't realize that's what it's called. Ride along, whatever it's called.
Yeah.
But ultimately, the culture is multifold, right? So I first started my career 31 years ago to do chemical dependency, substance abuse treatment with adolescents and their parents. So then it got me the idea of what addiction's all about. And then as you look at the culture, especially when it comes down to first responders, to go into, there's an aspect of alcohol dependence or some aspect of compulsivity. So I was familiar with that for sure. But I love it when it was more like about attention and focus. Similar to, I also do physician wellness, so ER docs, that type of thing, OBGYN. But it was interesting, at the ride-along, one of the guys said, "Hey, do we all have ADHD?" And he's looking at me, he's like, "I know I have ADHD, so all of us do, right?" It was so interesting because that is, one, that's both personal and professional to me. But ultimately, that type of culture is really interesting because either you're really, really high in energy or you're depleted. It's just exhaustion from sleep deprivation, the idea of going on calls. And going on some of those calls, both the idea of a normal kind of benign call where it's, not too much happening right there. And I'm sure that gets old for first responders over time, for sure. In fact, that's probably some moral injury right there. But the idea about it is it's also how that fluctuation really comes into also personal life, right?
Mm-hmm.
So that was where my connection became more clinical with the folks, because you can't just look at the professional life. You got to see what it's actually doing behind the scenes, like relationships. How do I feel? How's my sleep? Do I have nightmares? What are these calls doing for me? Like all these things became important to me is because as a trauma specialist, there's a bunch of it, right, for first responders. What I love about what we're going to talk about today is actually how efficient and effective some of these interventions are, because my experience also is that first responders don't really care for medication.
They're not big on medication. And that's like one of their biggest fears is if I go see somebody, they're just going to want to put me on pills. They're just going to give me some medication about,
pass me the beer.
Yeah.
Which is the irony you kind of hear sometimes. It's like, you know what I've seen put in your body and you're worried about a SSRI? And I get it. No, they're not wrong to be apprehensive about starting on
different
a
ways
medication.
to self-medicate.
Yes.
For sure.
Right,
Yes.
right. But it is funny to reflect on that a little bit.
Yeah.
Yeah.
So let's get into the clinical portion of
Sure.
things.
Yeah.
You want to start talking about treatments and things like that, but let's start at kind of the beginning where this all begins, right? Mm-hmm. So somebody makes a phone call, they pull the Frontline strong, and now they're sitting with you. They say, hey, we're going to set you up with this doc. So they come see you. The first step is to do an evaluation. Kind of describe the purpose of that evaluation and how that kind of helps you kind of zero in on where things are at, where things might go, where you think they should go.
Yeah, everyone's going to be a little bit different, right? So the assessment allows you to know where to go, because ultimately you need a whole story to really understand what kind of treatment you're going to be doing. So those assessments, for me, I can do psychological assessments, so I do have standardized testing that I do. Not for everybody, because people come in, they have an idea of what they want to do. I want to do neurofeedback. I want to do EMDR. I don't want to do that talk therapy stuff.
I'm here for this specific thing.
Yeah.
Yep.
Give me that shot, for lack of a better term.
Sure,
Yeah.
sure.
If I come in and see you and say, hey, I need to be seen for this, what does that assessment look like?
Yeah, that's going to happen probably over the first 2 sessions. First one's really just going to be a clinical interview. So we look at history, we look at the dynamics of what's going on in their family, relationships, marriage, divorce, children, substances, looking at anything that is important to them, both good and not so good. So what are your strengths? What are your things that you want to really work on? That clinical interview is where that therapeutic rapport comes from. That alliance is extremely important, especially with first responders, where they know.
They see that, they look for that personality.
And from what I understand, Dr. Kleis-Hulbert told us that the greatest indicator of you sticking with treatment and it being effective is the rapport the patient has with the clinician.
That's exactly correct. Yeah.
Right.
Yep. And connection, right? So
Right.
what
Just the human thing, right? That thing we can't put a temp gauge out there and measure the connection, the vibe. There's no vibe meter yet, right? But like that's a thing.
Sure.
Just the human thing.
Yeah, and that's just it. It's the idea of what's called attunement, right? How do you kind of connect to each other? And for a therapeutic alliance, for the therapist and patient connection, it has to be also like an emotional connection, right? So that's where change actually really happens. And it's not necessarily something that most therapists would say or do, right? It would be, we're doing cognitive behavioral therapy, CBT. This is going to be manualized. This is evidence-based. We're going to do it in this way. That doesn't really work for people who don't want to deal with BS, right? They don't want to
people that don't.
I just want to get in there. I want to see what this is about, and let's get it done.
Yeah.
Right. I'm a talker, so CBT's been my thing. Like, so if you like to just get after with a conversation, I'm your candidate. But I could see people that are so inward that don't have that button, that part of their brain that likes to just communicate through words. I could see how that would be rate limiting for them for CBT.
Yep. And not knocking it at all. CBT is fantastic. Can really be great for some, but they also have to get to another side of that because that's just really your cortex, your how you're kind of thinking, with executive function. So if I do A plus B, I get C. But a lot of these being more trauma-related, trauma-focused, it's a basis of that is not where you start. This is not a top-down process. This is a bottom-up process. So the idea of kind of what the body, the somatic, the physiological kind of sensory stuff that needs to be out, right? That needs to be processed, reprocessed actually, and then desensitized. So in that way, it's very different, right? So that emotional connection allows that bonding, which then allows you to get some of that work done because now hopefully you have the rapport that involves that trust that's necessary to do this work.
Now we can get the work done.
Exactly.
You kind of hear that phrase sometimes in these settings. This is where the real work happens.
Once you have that connection, you see a huge difference. Even with the peer support stuff, if we're calling somebody, we have no idea who they are, usually it's that first hour, you're just talking, like getting to know them, then they'll open up. It works in those realms, but you can feel it whether it's going to work or not.
Yeah, it's a relation. Right. It's a first date.
Yes.
It's a job interview.
Exactly.
Like in a lot of ways, it's the combination of a job interview, a first date, and a new buddy.
Let me tell you.
It's a lot of first dates. Right. You're not kidding there. So you really touched on during that initial process, that initial assessment, you're gathering all this emotional data, how they feel, what they're presenting with, what they're saying. You're putting it all together based on what you hear, and it's more of a subjective collection, right?
And holistic.
And holistic, correct.
So the whole person.
Yeah, right.
So the
Picture.
financial, right? Spiritual. The idea of, again, relational, when it comes down to professional, when it comes down to, again, spiritual, or things that are going to be very meaningful to folks.
Right.
And how often do we talk about that? We don't talk about these things.
Right.
No.
I mean, who do you even talk about that with if you even think about who is,
very few close friends if you have them.
Yeah,
maybe.
if you have them.
Yeah.
And if you have the time and things get bottled up, and here's the venting point to kind of release that.
Yeah.
Now, before we get into that, part of your assessment isn't just that subjective, hey, tell me what's going on with you. You actually do some objective measurement. Let's get into this thing, the QEEG, a quantitative, instead of qualitative, the quantitative encephalography.
Very good.
Got it.
Dude, I was impressed you made it as far as you did.
All right. I'm not even going to cut this part out. What is a quantitative electroencephalography, or QEEG, and what does it measure?
So the difference, people would know what an EEG, right? Electroencephalogram.
Yeah.
So the basis of that is going to be your actual brainwave activity. What we start with is that, right? So it is a raw EEG, but it actually gets translated into quantitative, which means that it's a brain mapping. So if you think about a brain wave that's like a speed, right? You go 1 mile an hour, you go 35 miles an hour. It's going to be a completely different experience. So the idea about that is that's what the brain mapping shows. And then it also does the ratios of where in the brain these things are happening. So, for example, a QEEG will take a look about, let's say, in the back of the head, posterior. You want to have what's called an alpha wave. That is your dominant rhythm, because we want to relax. The back of the brain is where all the input actually comes in, and the output goes out the front of the brain. So in that way, if I have a high fast wave, like a high beta, that causes anxiety, insomnia, hypervigilance. Basis of that is that's where then, and we'll talk about neurofeedback in a second, but the QEEG is the assessment that is quantitative. So that is very much a assessment of what the real live raw data is at that time. And we do it in two different states, meaning eyes open, eyes closed. So you have difference in both wave activity when your eyes are open and eyes closed, which we actually saw.
We actually went and did it.
That's what I was going to say.
Yes.
So we did this, and being paramedics, the immediate connection I had to an electrocardiogram is a quantitative representation and measurement of heart activity. Electrical signals going, what's going on. You can look at it and say that's either too fast, too slow, something's goofy, and it gives you a confirmation based on patient signs or symptoms. Just like a 12-lead EKG gives us more information of the whole heart, you're getting all the same type of squigglies, and to us it's just squigglies, the way to you EKG might be sometimes, or the lay person, to give you that data of exactly where and what's happening to that part of that brain through waves.
Exactly. And
Okay.
things do affect it, right? So it's not going to be constant. I mean, your brain waves are always changing.
So give us an overview of those various waves. There's like 5 to 7 different waves. What do they mean? Fast, slow, happy, sad? Like, what are you getting out of these things?
So the brainwaves themselves are the activity that's happening. So how fast they are. The measures hertz, kind of like sound actually, but it's a EEG, so it's neuronal. The idea of having what would be slow would be delta, very slow, which is actually our stage 3 sleep essentially, so non-REM sleep. But the idea about it, really, really slow. And that's noticeable in coma. You're actually in a deep, deep sleep. This is very unconscious kind of things.
When I'm not using it for tasks, it's all like the underlying functions that maintain the body are dedicated.
Yes.
I don't need to think. I don't need to be vigilant. Nothing.
Not at all. In fact, that's way up here. So the delta is the idea of kind of an unconscious. We get to theta is next, and that's 4 to 7 hertz. But ultimately what that does is go in subconscious. This is where more internal narrative is happening. And the idea about that is that also, if it's in certain areas of your brain, is not so great. So we want a faster wave in the front, but if we have theta, that means more attention deficit. So then that's how we look at, it's not a diagnostic tool, QEEG, but it does confirm, it does allow some data on some things. So delta, theta, alpha is a wonderful wave that we're kind of reducing in society right now, unfortunately. So the idea about alpha is very, very nice. It's sinusoidal. It's just up and down. And what happens there is we get a relaxed wave. And this could be even what would be meditative, but we're getting more limited on that because of how much, next one, beta is. And we have low beta, beta, and high beta. So low beta is actually where we really want to be. This is the zone. This is where like CEOs, high athletes actually train for these things to get between 12 and 15 hertz. Why? Because it looks like an alpha wave where you're relaxed, but you're actually processing. So you can chill and you can get very much things done and very productive. So then you go to beta, it's a bit more processing, so you're getting the task done. Just like if you're on a call, for example, you're using a lot of beta. High beta at that point then becomes too much. So it could be over-processing, which would be rumination, which is then not good because what are we doing? We're just kind of going over and over the same thing again and again. And high beta is where, again, anxiety would be, that type of thing. And it depends on where in your brain it is, because the brain is all different functionality. Quick story on that. Late 1800s, there's a fella that is a manager on the railroad. And there's a tapering rod, it's called. They put a little TNT in there, and it hits so they can get, more railroad track down. Mm-hmm. Essentially, this tapering rod goes to this guy's head. He lives. It actually was one of the first understandings that the brain has specific functionality in different locations of the brain. So because this went literally almost through his eye, just straight out his frontal lobe, and he lived, his personality changed because some personality is actually based in our frontal lobe. So this is one of the early studies that says, early experiences that says, how do we now look at the brain?
There's the data.
Yep.
And
if this part's gone, it must affect how he talks, acts, thinks, feels.
Which is also things like traumatic brain injury. So ultimately, if you get in an accident, right, some patients that you see on call, they're going to have TBI. So what is going to be the deficit potentially that happens? Or how do you train that, if you can, if it's not totally damaged?
So you can literally see these experiences people are telling you. So you got the experience they're talking to you about. You then get this measurement of how that, what do you do with that data? What you combine those two and then you come up with a treatment plan?
You do. Treatment plan would be the intervention that you're working on together, right? So this is not just I create it. It's going to be a co-developed treatment plan. But the idea of it is from the psychological assessment, which is also going to be objective because it's their self-report, or things like neurocognitive exam would have very much data such as what is your working memory. So that's the beginning of memory where if I give you a phone number, could you do something with it, right? Short-term memory, a little bit longer, right? Long-term memory gets crystallized. But the idea about that is now you can get that data, get the support from the QEEG to recognize what it is and where this is happening. And then you start to look at what the intervention is going to be. So is that going to be, we'll talk about neurofeedback and or EMDR. I think people are more probably familiar with EMDR, I would think, but we can spend some time with neurofeedback.
Yeah. So let's hit on the neurofeedback first.
So from the QEEG, which is the initial assessment, the idea about it is then that says maybe this is what the protocol is going to be. Protocol meaning how are you going to orient what you're going to do. So for example, neurofeedback is a training, and it could just be in one electrode. Could be the whole brain, whatever it is that you're trying to get at. I do two primary protocols or interventions. One is for executive functioning. So focus, attention, concentration, get into a place to where now the delta goes down, because delta can be really high for multiple reasons, and we can put cannabis in there because it's a really high delta. But ultimately, the protocol says, yep, let's do something for focus and also emotional regulation. So folks who don't get a lot of sleep, they love this, right? So ultimately, it's getting a greater alpha that you're trying to increase in the back of the brain. And for folks who have trauma, that's a big deal. Well, for trauma, I don't want to go to sleep. Why? Because I can have nightmares. Who the heck wants nightmares?
Yep.
So then what do I find? I find similar things like alcohol, cannabis, different things. These things will affect your EEG. Some of them are actually counterintuitive. So for example, Xanax was a big thing for a long time, and a lot of prescribers now are not actually giving that anymore. A little more fast acting, and it's actually only supposed to be given for like 6 months. People take it for like
years.
Yeah.
Yeah.
So part of it, though, that's counterintuitive for those what's called a benzodiazepine is the idea of all those 19 electrodes are showing beta.
Mm-hmm.
That's very counterintuitive because ultimately you would think that it would show a lower wave,
Right.
but it actually
Right. You're
extends
talking
to
about
higher
taking a
wave.
benzo to chill you out, and you said that a beta is more of like, now you're like having to think things.
A higher
Processing.
function.
You're planning. Yeah.
Yes.
Yeah, process. So it's a little bit
Processing.
Some of those are there, but the neurofeedback has to be on a good assessment, right? So that's where a lot more of that, again, clinical interview comes in. What medication are you taking? What's your sleep pattern been like? What substances are you using? What stressors do you have? These are all different things that we would look at before we even do the assessment. But then from there, it kind of makes some sense. But the idea about it is then from that assessment, from that psychological assessment, all these things now say, what's the protocol going to be? Neurofeedback now is a training where it could be anywhere between 12 minutes and 30 minutes where you put a cap on, just like a QEEG. And you have different interventions that are for operant conditioning. So this idea of reinforcement. So if it's positive reinforcement that we're trying to do, so you want more alpha in the back of the brain to sleep or less hypervigilance. The idea about that is then you get a tone or you get a visual that then allows that positive reinforcement to then allow the brain go, oh, I really like that.
Mm-hmm.
So ultimately it's the brain wants positive reinforcement. So
Yeah.
what works, we want to do again. The problem sometimes is that the idea of this operant conditioning or positive reinforcement, it can actually become a little bit not so good. So for example, I had a really bad call and I don't want to think about it. So I avoid it. And then I avoid different things. Well, the brain goes, oh, that's reinforcement. I avoid it. I don't want to think about that. So then that's maybe not the best of all things because that's short term, but not really a long term
What
solution.
fires together, wires together. The old adage.
Yep.
So help me
I came from
understand.
neuroscience.
Yeah, right. Help me.
Whoa, now. Hold on.
Help me visualize the person in that room, what they're wearing, what they're doing, how you're manipulating or at least engaging with those waves in their brain.
I'm your patient. Walk us through it. What's that going to look like?
Yep. Just coming in for a quick setup. So ultimately, if it's going to be all 19, that's a lot, right? That's going to be maybe a 15 or 18 minute type of thing or setup.
Yeah, when you say setup, you put the cap on, you put the gel in there, you're hooking up electrodes, there's a connection, making sure you're getting through the hair. It's a thing.
It's a very wired up.
Yeah, you're and it's kind of comfortable. You're chilling.
It's not bad.
Yeah.
It's not bad at all.
It's
Yeah.
So you're trying to
Don't do your hair. Just,
Actually, you can't use conditioner.
Right. That's what. It's
that
using a
actually
nice
messes
clean
up
hair
the-
to get through. Right. Right.
But yeah, you sit down. A person, the tech, myself would be behind, right? And the idea of it is getting the cap on, and the electrogel. It is like a conductant, right? So the idea of you have to get to the scalp because what it's looking at is like the top 1 millimeter of your brain activity.
Yeah, just like the stickers we put on your skin for a EKG.
Yep. So then the cap goes into an amplifier that amplifies it 20,000 times, right?
So
That's
these
how
are
we get to see the
microwaves
EEG.
that you're really, literally small little waves that you have to really make bigger to even see and analyze.
Correct.
Copy.
So in that way, the neurofeedback, you get that setup, maybe 10, 15 minutes for the most part. And then you either have an eyes closed or eyes open intervention. What's the difference? If I want to do emotional regulation, we're probably going to do eyes closed, right? Increase alpha. So when our eyes are closed, alpha is actually about 30% difference from the time that we have our eyes open. Because if you think about it, right? If I close my eyes, I don't have to associate anything. And all the visual is gone, but all that visual association is really for one big reason.
So like your processing
Safety.
my RAM, the RAM can go elsewhere on this one because I'm just shutting off what I can see. Data input is now vastly decreased.
Yep. So fast wave, slower wave.
Got it.
And then the other one is eyes more open is more for executive functioning. So the idea of how do you get more focus, more planning, more organization? How do I get more task completion? Things that are going to be even more memory, actually. So the idea about this is, those are interventions a little bit different. So you'd be looking at a screen, could be a video that you want to watch. Be like skiing, photography, horses. It doesn't matter what you're watching, but the idea of you have a dimmer over it, which means that there's a threshold that you have to reach, and then it would lighten up, and then you can see the video much better. And then if you're not in that threshold, it goes down, and then you're like, okay, the brain, that works. I want more of that. Mm-hmm. And then that's the positive reinforcement of that operant conditioning.
And those maneuvers are manipulating the wave.
Yes. So on the software side of it, my end of it, it's the idea of what is the protocol going to be? So what are we going to do? So those 7 different ways we just talked about, including low beta, beta, high beta. Gammas, we don't do much with gamma. It's really, really low. It's very, very fast. And that's a whole other story because if we had more gamma, we wouldn't even be having the talk. You'd just be able to The part of it there is that as you're looking at that, the protocol can change. Like if I want to have less high beta here, more theta, because now you want someone to actually get a little bit lower, so now they can be more introspective. And one of them, it's really interesting. It's alpha theta. So the idea of a slower wave, theta is like the second wave up, alpha is the third. If those cross, and that's what you're trying to do, that's actually deep recovery work. So what you're doing in the relaxing wave, alpha, and the theta is that introspective wave. If those begin to cross, those are actually times of internal processing.
So you can actually see the therapeutic effect in real time.
And usually after a training, it'll be like, what did you notice from this session? And the session could be 30 minutes, could be 15, 20 minutes, whatever the protocol stands for. But and then, I felt really relaxed. I felt completely focused. Oh man, I was off the beaten path today. I was like, and I'm like, I saw the delta.
Who's really a candidate for that?
That's an excellent question.
Yeah.
So those 2 things I was just talking about, emotional regulation and executive functioning, those are huge, right? So do a lot of attention deficit, ADHD. And when it comes down to trauma, that's one of the large things is to get a person to be able to sleep, to be able to regulate emotions. So if I have a trauma response, what am I doing? I'm off the beaten path.
You're firing up.
Haywire.
Yeah. Place in our limbic system, our emotional
I'm just
centers.
picturing the squigglies.
Yeah.
All the squigglies are going nuts.
The amygdala just firing.
Yeah.
It's just going off. So the idea about that is the brain has 3 different kind of mechanisms. One is if you go into the brainstem, this is really about alertness. And then the next is about danger. No matter what room you walk into, your brain automatically goes, am I safe? Is this a secure place to be? Now, that's everyone. That's the brain, how that works. Now, a person with post-traumatic stress, that's the whole basis of now saying, I need to put my back to the wall. I need to be looking at everything. This is the stimulus, right? Well, we can see that on so that's the idea of that. And the typical duration is about 20 to 40 sessions. And those are done 2 times, 3 times a week. So this is like this is a muscle.
This is a commitment.
Well, it's like going to the gym and doing some reps, right?
Right.
Doing some reps for the brain, and you're making it stronger.
And that tells me the type of patient that benefits from that's willing to do that is suffering.
Or committed to change.
Yeah.
Wow. The ratio of me being committed to change is directly related to how bad something sucks.
True story.
Yeah. Yes. Yes.
I can avoid a lot of shit
Until you can't.
until I can't.
Yes. Yes.
I think it's Tony Robbins who says something like, change only happens when the current situation is just too much.
That's exactly my point.
Too much pain.
Yes.
Exactly.
And then
Whatever
you're like,
it
I
is,
gotta
the
get out of
overload.
this.
Exactly.
And then you go, all right, well, I should probably get this taken care of.
Right.
Yeah.
Yeah, so like that's when people say, well, oh, geez, well, maybe it's not for you yet.
Well,
or whatever it is. I mean,
but we
and it
do-
isn't for everybody, right?
But along the way, we do an assessment.
Right.
So 10, 12 sessions in, okay, where are we at? So we'll do another Q, a QEEG. And then if we do another Q, what's that protocol not going to be? What's that intervention going to look like?
Where are we at?
Yeah.
Are we on
Yeah.
a path? We did a bunch of workouts.
What do we go up? What do we go down? Right? If we're
Yep.
going to inhibit something. Yeah.
Right, just like when you go to physical therapy, I feel like it's a lot of the same stuff. They can measure it and go, okay, it's this strong week or whatever, and then we do a bunch of stuff. We come back, all right, measure it again, and that may or may not increase or decrease the next steps.
And like what I like to tell them is it's more of a surgical strike. We're going to get in there, we're going to find the areas, and we're going to hit it, right? And it seems to me that people are willing to at least give it a chance because they're like, okay, I've tried this, it hasn't worked. Why not try this? You can still see your therapist and do this at the same time,
Right.
correct?
Right.
Right? But one of the other things that I really wanted to bring up and something that I personally have done myself for years is EMDR. Like, what is EMDR?
And so we just talked about neurofeedback. That's kind of how you get regulated. EMDR is now how it actually gets processed. So it's the how and the why, if you will. Eye movement desensitization and reprocessing, EMDR. So the D, desensitization, is going to be out the body.
Mm-hmm.
We need to get that out. It's looking at how you are functioning internally. So what's the cognitive aspect of this, which is the reprocessing? So for example, it's a trauma intervention, as you mentioned. So now you're looking at an actual event. So this is not an overall, this is a target memory, right? So in this way, the earliest and the most significant is usually the one you start with first. So it's not the call from last week that took me into a frenzy, right? Because the brain actually hasn't consolidated that yet for about up to maybe 90 days. So really EMDR is not for acute, it's actually for after the memory's been consolidated. But the basis of it is now that target memory, you have what's called a negative cognition about it. So I'm ashamed, I'm worthless, I'm not lovable, these type of things, which then goes into a preferred or positive cognition. I did everything I possibly could. I am the person I know I can be. These are different. But the idea of it is pre and post within 1 to 2 sessions. I'm not saying that just generally. This is effective. It's called an intensive. So this is not an hour session, right? This is more like a 2-hour session. And the way I do it is I do it back-to-back days. So if you come on Tuesday, you're going to come on Wednesday. And as you get through most of that work done on the first day, really you're just consolidating it again, kind of giving it a reappraisal. So it's the basis of kind of putting it now into that new form. And if we got it out of the body, if the mind looks at it differently, now it's reprocessed.
Mm-hmm.
You're not re-experiencing the trauma while you're doing this. You're processing it in a way that is what's called BLS, bilateral stimulation. Mm-hmm. And what these are is it could be auditory, so you have some earbuds in, you have a light bar that's the visual, or possibly someone's finger going back, and then you have tactile, so you have little buzzers kind of a thing in each of the hand. When they go bilaterally, so back and forth, back and forth, back and forth, back and forth, speed matters, right? So the faster it is, the more processing is going to happen. And when you slow it down, you're kind of putting in some resourcing, right? Some positive things. Why is that all very important? Because it's not stuck anymore, if you will. It's the idea of now the full functionality of the brain by the bilateral stimulation is the thought about it. It's also relaxing, right? But the point of it is you walk out, and hopefully, I'm not saying this is 100% for folks, obviously, but for a good majority of folks, that target memory is no longer sensitized. It's no longer in a negative experience.
Doesn't turn my amygdala on.
Yeah.
Correct.
I can think about it.
Yeah.
Yeah, so to speak from my personal experience, how I experienced it is when you said it is stuck, It's the event, the sentinel event that we're going to focus on during that time that's causing the feelings that you're getting of what we're here to remove. So specifically with me, there was an incident that injured my daughter, and I wanted to address that because every time I thought about it, it brought up a lot of very difficult feelings. And so we would focus on that event after we have now activated both sides of the brain. And after a while, we are now desensitized to the discussion of it, talking through those exact things. And then the reprocessing is, let's set that in stone. This is how your brain's now going to fire every time you think about this. And it's weird. It seems like magic. But you're literally saying is, I measured these brain waves. We talk about this stuff, and it is not good. Obviously, you're experiencing some big processing issues, which is leading to all your symptoms. Now let's do this thing where, hey, hold these two things, jump on one foot, pat your head, and rub your belly, and then I promise when we talk about this, you're going to feel better. It almost feels like that in a way, right? To the lay person. So it's interesting how you can say. Yeah. Well, yeah, it feels like it, but it's obviously evidence-based and works.
For sure.
Your mind ran a marathon in that time, and it's amazing to me every time I did it was how tired you were when you got done. I had a bad run at work. It was a child, same age as my son, who drowned. So every time my son was around water, if I wasn't in the water with him, I was hyper vigilant to the max.
Sure.
And after doing that, multiple sessions, our neighbor had a birthday party, and it was a pool party. I caught myself sitting just talking to another parent, and I hadn't thought where my son was for 20 minutes, right? But before doing that, I would have been standing on the edge of the pool, never taking my eyes off
and
of him.
It's not like you're not being not safe. You're just rational.
Really, what I found what it really did was it took that experience and made it okay. It made it to where that experience happened. That doesn't necessarily mean it's going to happen to my son.
It's more normalized.
Right, it's more normalized.
Because you reprocessed it to give it a rational reaction to the situation.
Yes.
Let's walk through how you do that. This doesn't happen in just one little thing.
Right.
So ultimately, you start off with the speed that's comfortable, that you can sustain, the light bar, the visual. And then, after a short amount of time, you take a breath, and then you process what it is. So what's your body like? What is your visual? What's the feeling, emotional feeling? And then is there potentially a message in there that's a little bit different from what it was before? And then you do another one. And you do another one. You do another one. You can do this 6, 7, 8, 9, 10 times. That's where the exhaustion comes in, because now the body is going through it, because now that target memory has you hypervigilant on point, and your body's going to feel that while you're doing this process. And it's like, holy moly.
You feel it. You feel it while you're doing it.
But the idea about that is you're not trying to re-experience what it was from the initial point.
Desensitize it.
You're desensitizing it because you're actually processing it in now a different way.
And you need those reps. You got to get reps in.
Correct.
To make the behavior change and literally the wave change.
Yes. But just to clarify too, you're not always focusing just on target memory.
Okay.
So it's kind of like, let's say you're in a car or a train, right? And you're just looking out, right? Things are just going to go by really fast. That's an opportunity for other things to come in because it's probably associated, especially to your neural networks, your neural activity. So here's a pool, here's my son, here's me on point, right? But that could be with maybe when you're now going to be at the ocean and something else is coming in, because now that's a fear-based thing and those might be connected. So what I'm getting at is other things can come in, processing what those are, but always going back to target memory to make sure that as these things are connected, is it becoming reprocessed, desensitized, and now can you reinforce that positive cognition? So in that way, you are reinforcing that new cognitive processing, and the body now hopefully is no longer storing it.
Which is the storing is causing the feeling, which is causing the suffering.
Yep. And the goal itself, whether it's 1, 2, 16 sessions, depending how foundational the target memory actually is, because that's why you get the most significant, the oldest first, is because that is where is the house built on cement or is it based on sand, right?
Yep.
So the foundation, if it's on sand, how is that now reorganized? And it's repetitive over and over and over again. So that negative cognition is internal narrative. With that said, it's wonderful to get to what's called 0-7 clear. So the negative cognition goes down to 0 out of 10. Positive cognition goes all the way to 7 out of 7. And this is how a person is self-reporting what they feel. And now clear means there's nothing being stored somatically in the body.
Just like we said,
negative response.
Feeling emotions will express themselves some way.
One way or the other, they're coming out.
This seems like a evidence-based way to kind of grab onto that sucker and get it out.
Quick story. There was a gentleman, leadership at a firehouse, been on the job for a couple decades. Processed a very early call, like in the first month or two of being on the job. So he walked around, shoulders all the way back, propped up, always on fight or flight, always on the guard. We did 2 sessions of EMDR, and this doesn't happen for everyone, but
sure,
he's completely erect, just back is completely straight, and then by the time we processed, he kept falling back further and further and further into the chair. And he looks at me by the time we're in, and he goes, "What the hell did you do to me?" And it was such a fantastic, significant shift. And it's usually quite long-lasting, too. Sometimes you need a little bit of a recap, if you will. Coming back to it maybe 6 months later, 2 years later, 6 years later, whatever it is. But most of the time, that has been re-cemented, and it works, right?
It works.
How long was that ago?
Since it happened?
Since the EMDR that you
felt
different?
Wow. It's probably been 6-7 years now.
Yeah. And has that persisted?
Yeah. It's insane how well it works.
Yeah.
I mean,
it almost doesn't make any sense.
It does. I mean,
well, take a small part, right? If I just stick that on a piece of paper, right, and I say this is where this is at, and I'm just putting a paper like this is not anatomically correct, but it's in your brain, it's stuck. If I open that up now, it's not magic. Like this is not
right. No, it's so simple.
So the idea about it is now I can process that with more brain power, more opportunity to look at it in a different light and different perspective. So now, what is A? You just now went through B, C, D, all the way to X, right? And now X is completely different from where you started, which now means what? Completely different experience.
When these events happen, they get stuck. How does early diffusings, debriefings, does that help make that less stuck in that spot to where it's easier for EMDR and neurofeedback and stuff like that to work?
Fantastic question. So 2 people can go to the exact same call and have a very different experience. Let's just say I've gotten into a motor vehicle accident. I can walk out and go, damn, my car, I have to fix my car.
Mm-hmm.
Other person goes, I can't breathe, I can't walk, right? It becomes a completely traumatic response. Why is that? So it depends on a lot of what would be protective factors. So do we have a lot of support? Do we have debriefings after events that are really significant? And do I take the opportunity to actually discuss what it is that I'm going through? Sometimes that happens right afterwards. You know, it's open, if you will, and you start to process it. In that way, can that be decreased immediately if the protective factors are there, right? Are people taking it seriously? And is it supportive? And it's like, hey, man, I'm gonna check on you later. Is that okay?
Mm-hmm.
And it's like, okay, yeah, that feels better. But sometimes those don't get discussed. And then it's like holding on to this one thing. Typically, that's something shameful. And I don't want to share this.
Mm-hmm.
I didn't do everything I could possibly do. I know I could have got that hose quicker.
Mm-hmm.
I know I could have, whatever. But the idea about it is, if people don't talk about that shame, they get stuck.
So that's how you get there in the first place.
Which is secrets. But I'm keeping the secret for myself to not actually process it.
So the early diffusings, debriefings, peer support actually helps that to not get stuck or
healthy coping mechanisms, healthy lifestyle, sleep.
If the person's open and can have that type of vulnerability.
Okay. Yeah, right. There's many. It sounds like there's many things that can influence it positively. One of the things being if you need a CISM or debrief.
Yep.
That can, if you're open to it,
if
just
you're
like
open,
everything.
Yeah. And it makes sense, right? That's going to happen over time. Maybe I see how, if I'm a probie and I see my senior, ultimately, if they're talking openly, that's probably going to be better for me. But I'm just not going to open up because what's going to happen? Well, it depends on the culture of the house.
Stigma.
Exactly.
So,
all this stuff.
you P word, you whatever, B word, whatever it is. Right? So all these things, and then it becomes the idea of why would I talk about this at all?
Right.
Yes.
So the culture matters too.
Okay.
Absolutely. So, Doc, as we close out here, what is one important message you want listeners to remember or know about seeking clinical help if they think they need it?
So it's looking at what you have as capacity, for example, right? So how strong are things? We set up a whole, we as in the U.S., set up a dome on Mars and tried to terraform Mars, right? So this is years back. But the idea about it is the trees that they planted in this dome grew fantastically. Tons of carbon dioxide. It was fantastic. They grew beautiful trunks, beautiful canopy, and then they all toppled over. Why? Because there's no wind in the freaking dome, which means that there's no adversity to actually strengthen what will be the roots of the tree themselves. So therefore, we can have beautiful growth, but if we don't have that stuff underneath, right, that's really strengthened, and I can look at adversity, which means I'm going through my emotional regulation, I'm going through those debriefings, I'm talking about things, I'm getting these things done, that's going to strengthen those roots. What's the way to kind of think about this as final comment? You're not broken. There's nothing broken there, right? But what is it? It's adaptability. So ultimately, I just adapted to the negative experiences, potentially, of what it is. I'm not broken. My brain's not broken. My behavior is not broken. My emotions are not broken. I am not broken. What I am is adapting to what it is that I already know. What therapy intervention does is it says, you just adapted. Let's take a look about how to treat and train you differently. Because if you can train it the first time, you can retrain it again.
And that's the elasticity,
that's
right? That's the big one, is that there's always hope. And what's nice is for those people who don't love the idea of medications, as we've mentioned earlier, especially in the first responder community, we like to avoid it. There's lots of good options you can try to make that feelings or that suffering, that silent suffering, go away.
Yeah, but the one thing about medications I would like to say is that, you know what? They are something that is a tool. So ultimately, if you had to lift someone out of their condo and get them into the bus, right? Are you going to do that with a tool, or are you going to try to do that alone? Most often, you're probably going to use the board, right?
Right.
Yep.
Well, why?
Makes
Because
it
it's a
easier.
tool.
It's a good leverage tool.
So, so the idea about medication is that if it's really a place that can get you to a place of deeper work, that's where the effectiveness and the efficacy of medication is great. Doesn't mean it's going to be long term. It means I just got to get myself into a good zone, right?
So let the real work happen.
To let the real work happen.
And you might need those meds to help you on the path just to get to the gym to work out.
That's correct.
For lack of a better.
Absolutely correct.
Well, Doc, it's been amazing. We're going to have you back.
You're definitely coming
Yeah.
back.
You're coming back about sleep and more meds. We're going to talk about that again.
Yes.
Okay.
Yes.
And you're going to be here for a webinar this summer. We'll be putting that out here.
I'll look forward to it.
Yeah.
Yeah.
It's going to be great stuff. Thank you, sir.
Thank you.
Thank you for listening to the Minds on the Frontline podcast. We have more great content coming out soon. Please check us out on YouTube, Instagram, Facebook, X, and LinkedIn. And make sure to like and subscribe to all Minds on the Frontline podcast social media channels. Thank you, and have a great day.